So let me just say that first, I want to welcome everyone on behalf of the SPAC Train leadership, the principal investigators, the MPIs who are here, Professors Nodu, Professor Fred Safo, those are the ones you can see, and then even the co-investigators. Please, you're all welcome to this day 2 of the multidisciplinary training in management of sickle cell disease. I guess later on in the course of it, we are going to hear from Professor Nodu and many of the other MPIs about the SPAC train program. Today we have a part session just like yesterday. We have acute complications like acute chest syndrome, priapism, and then, of course, acute stroke. And we're starting off with acute chest syndrome. And the person who is going to be presenting acute chest syndrome, the topic acute chest syndrome is Professor Alex Osei-Akoto, who is from the Department of Pediatrics, Kwame Nkrumah University of Science and Technology, and also a consultant pediatrician with Kumfanoki Teaching Hospital, Kumasi, Ghana. Professor Alex, can you hear us? Hello, Professor Alex.
Hello, Max. Good morning.
So your slides are up, so you can go ahead. You're welcome. Thank you.
Thank you. Thank you, Maxwell. Good morning, everyone. And standing on the protocol just established by Maxwell, I want to welcome all of us to today's meeting. And on behalf of the SPAC Train fraternity, we want to use this platform to learn something about sickle cell disease so that when we meet our patients, we're able to, as it were, offer them the necessary support and interventions. And so I want to thank the organizers for inviting me to share some points on acute chest syndrome as we see in sickle cell disease. My name is Alex Osei-Akoto, and as Maxwell said earlier, I'm at the Kumfanoki Teaching Hospital and also at the Kwame Nkrumah University of Science and Technology in Kumasi in Ghana. So talking about acute chest, we would look briefly at sickle cell disease. I know yesterday much was said about it, so I will not spend much time there. Then we'll go into acute chest syndrome, look at the definition and the risk factors, as well as the pathophysiology of causes that lead to acute chest. We'll look at how patients present clinically and what we must do for them in terms of laboratory investigations leading on to management approaches. We'll say a bit of prognosis and complications and end that way. So yesterday we learned about sickle cell disease and everything about it leads to the hemoglobin losing its oxygen and becoming sickled, in the rest of becoming sickled. And that begins the journey of all the complications that exist with sickle cell disease. So the complications as listed here, vaso-occlusive pain episodes or pain crisis, as many of us will call it. Today we'll hear about stroke. Yesterday we heard about anemia in relation to splenic sequestration and all others. Today we are hearing of acute chest. Other complications as listed here, priapism, which we would hear about today. And so You find this pictorial diagram of a person with sickle cell disease can suffer from many complications from the head to the toe. So the head, the brain, the chest, the lungs, the heart. In the abdomen, we have the stomach, the liver, the spleen, genitourinary system, musculoskeletal system. All the systems in the person with sickle cell disease is not spared. And so you find that they are both acute and chronic complications, as shown here. The pale green showing chronic complications, the pale yellow showing acute complications in sickle cell disease. Since we would have this presentation distributed, I won't spend much time in this diagram, but just to say that we should keep in mind that there are so many complications that result in patients with sickle cell disease. So what is acute chest syndrome? Simply put, it is a life-threatening complication of sickle cell disease. Some people refer to it as a dangerous life-threatening complication of sickle cell disease. And basically, it is characterized by a new pulmonary infiltrate on chest X-ray and accompanied by symptoms of fever, of chest pain, hypoxia, and signs of respiratory distress, including fast breathing, chest indrawing, and other things. Acute chest is the most prevalent acute pulmonary disorder in individuals with sickle cell disease. And about 50% of patients with sickle cell disease would experience at least one episode of it in their lifetime. The peak incidence of acute chest is observed in the pediatric population between 2 and 4 years old. So, you see that it starts quite early. And among adults, about 70% of acute chest syndrome episodes are secondary to vaso-occlusive pain episodes. So here I would say that be wary of that patient who comes in with acute pain in the lower limbs. We need to watch this patient because he or she could develop acute chest even whilst on the ward. It is the most commonest cause of death in individuals with sickle cell disease, accounting for nearly a quarter of all deaths. That is 25% of all deaths in sickle cell disease. Mortality with acute chest can be 4.3% in adults and 1% in children. So mortality is highest in adults than children. It is the syndrome. And in our center, we published a paper last year which showed that 25% of all our sickle cell pediatric admissions was due to acute chests. Pain events was 40%, followed by acute chest 26%. The incidence is higher in children, as already said. The cause of the disease tends to be milder in children. And in children, the pathology mostly happens in the upper lobes, whilst in adults, it usually happens in the lower lobes of the lungs, and especially it is more multilobular. We have already said more severe and higher mortality occurs in adults. Acute chest can occur in all phenotypes of sickle cell disease, HBSS, HBSC, all the others, but those with higher and those with severe forms, HBSS and HBS beta tau are the most vulnerable. Of the complications of sickle cell disease, acute chest happens to be one of the cases that can send a patient into ICU. So we must be looking out for it. It can lead to lung injury, leading to chronic lung disease, especially in adults. The following can be risk factors for acute chest patients. Infections. An infection can be systemic infection or pulmonary infection, can give rise to acute chest syndrome. But embolism from marrow necrosis, pulmonary infarction, or hypoventilation from any kind of cause in the sickle cell patient can lead to acute chest. Vaso-occlusive crisis, we've said it. Then the use of opioid analgesics. And so if a patient is on opioids, we need to look out and monitor well, because it can lead to suppression of respiration and therefore leading to hypoventilation. A younger age is a risk factor for acute chest. Then within the sickle cell population, those who have very low fetal hemoglobin concentrations are at higher risk. And also those who tend to have steady state hemoglobin levels, higher steady state hemoglobin levels. HBs 11 and above is usually a risk factor. Then those who have higher steady state of blood cell counts, that is higher WBC counts, is also a problem for precipitating acute chest in individuals. If a sickle cell patient has a comorbidity of asthma, it becomes a risk factor for the development of acute chest. And it is well established that tobacco smoke, either by way of exposure, secondary smoking, or primary smoker, is also a risk factor for acute chest. And then if there has been a previous episode, it also becomes a risk factor. Yesterday we heard that acute sequestration crisis, that is splenic sequestration crisis, if you have one, you stand the risk of having another. Acute chest is another complication that also does same. We look at this slide, looking at various things that would, as it were, trigger acute chest in the individual. The basic problem is vaso-occlusive crisis within the pulmonary vasculature, where polymerization occurs with adhesion and thrombosis and vaso-occlusion that can lead to in situ pulmonary thrombosis, or can also lead to pulmonary infarction. And each of these could trigger acute chest syndrome in the individual. In the same way, when you have the sickling process leading to hemolysis, the heme that is discharged into circulation can injure the lung parenchyma, setting off a process of acute chest in the individual. If we go to the bones, we know pain, we've said pain crisis is a precipitating factor. Here, if you look at the rib cage, if any of the ribs is affected and there's pain in there, it can lead to splinting of the chest, leading to inability of the patient to, as it were, ventilate well, and therefore could be hypoventilation with attending atelectasis leading to acute chest syndrome. There can be, when there's bone marrow necrosis, it tends to throw off fat emboli into the circulation. And this is also another way that acute chest can develop. And with the pain and all that I've said, that if we try to, as it were, treat the pain with opioids and we don't look at things very well, we could induce opiate respiratory depression, also leading to hypoventilation. All these things happening will lead to shunting of blood and desaturation hemoglobin, leading to decreased oxygen delivery and therefore hypoxemia. And that could also kickstart another wave of vaso-occlusive crisis. So by way of diagnosis, when a patient has acute chest, how do they present? By way of symptoms, fever, that is high temperature, usually 38 degrees and above. Of course, chest pain because of things happening in the lungs, could be painful and all that. There's usually an accompanying cough, shortness of breath, fatigue. There can be the possibility of hemoptysis, especially in severe cases caused by infarction, pulmonary infarction. They can have hemoptysis. The signs that we see on the patients would include tachypnea, hypoxia, as will be evidenced by a low oxygen saturation. Some patients develop wheeze. And if you percuss the chest, you find clinically that they have chest dullness with a reduced air entry, crepitations, bronchial breathing may be found, and acute chest could also lead to a complication of pleural effusion, and therefore you can find these things on the patient. So clinical examination is very, very important in patients with acute chest syndrome. In all these, I would say that a good measure of suspicion should always be kept. Hematology, we need to do full blood count, looking at HB. Usually acute chest could precipitate a decreased hemoglobin level. We have said that if there are lots of white cells in acute, we know acute chest also can lead to leukocytosis and all that. So we should look at the FBC. Reticulocyte count is very important. Yesterday we learned about that. In acute chest, it is very, very important from the beginning to look at the blood group and then cross-match, because there can be a deterioration of anemia in patients with acute chests, sometimes very sudden, which would demand blood transfusion. We should also look at the biochemistry, looking at LDH. Very high LDH could signify lots of red cell breakdown. We should look at the arterial blood gas if we have facilities for it. we have mentioned that infections is key, especially in children. Pulmonary infections is the leading cause for acute chest syndrome, about 30% of cases. So blood cultures, after all, they've come with very high fever. So you need to find what is causing the fever. So blood cultures, if possible, do sputum for microscopy and culture. Don't forget to take urine for routine examination as well as culture, because UTI is also an infection that could systemically affect the lungs. Then radiology. Radiology is key for the diagnosis of acute chests. And so technically, it is defined by way of a new infiltrate in the chest. And you can only use chest X-ray to do this. CT pulmonary angiogram becomes important when there's a suspicion of pulmonary embolism. It is now known that we can even do bedside ultrasound. In the chest, and that can be used for diagnosis. So X-rays, this is an X-ray of a patient who developed acute chest, a 24-hour X-ray, 48-hour X-ray showing patchy consolidation here, which has increased at 55 hours and at 72 hours. There can be other things that can make acute chest, so we need to, as it were, exclude them. I've said already that people with asthma are at a higher risk of acute chest. And so because they can present with wheezing, if you find a patient with wheeze, think also of asthma as you would want to exclude acute chest. Yes, we know that pneumonia is also very rampant in our part of the world. So think of it as its differential. Pleural effusion, I've mentioned already, embolism, and others, especially in the adult population, like aortic dissection, acute coronary syndrome, respiratory distress syndrome, acute respiratory distress syndrome, which can also be developed when some people have acute chest syndrome. Would also be a differential here. So when we have made the diagnosis, we need to manage. And the management pillars, we're looking at oxygen therapy. We're looking at pain management. We're looking at fluid therapy, antibiotics, blood transfusion, incentive spirometry. These are all very, very important. And it is recommended that bronchodilators can be used in patients who wheeze. And some authorities also even talk about the use of steroids, especially in those with wheeze and other events. But it is thought that when you are using steroids, you only shorten the hospital stay, but you increase the risk of readmission by way of pain crisis and subsequent acute chest development. So with regard to oxygen therapy, supplemental oxygen to maintain oxygen saturation above 95% is very key in the management of acute chest, because you want to improve oxygen carrying capacity of the blood to improve oxygen tissue delivery. We can prevent alveolar collapse by using incentive spirometry. And we'll look at it in the next slide. Patients who are in clear respiratory distress, whose oxygen falls to 85% or less. And some people even say that if you have a acute fall of 3 percentage points or more from the baseline, you must be getting ready to escalate therapy in ICU care. Fluid therapy is another thing we need to look at when we are treating acute chest. And here, we need to individualize the amount of fluid to give depending on the patient's fluid balance or hydration status. Patients are usually too ill to consume fluids orally, so most times we resort to IV hydration. But here we need to be careful with the amount that we give. It is recommended that we should give not more than the maintenance dose or the maintenance amount for hydration of the patient. So usually some people say that you should give a third of the maintenance or maximum 1 maintenance dose so that you don't cause pulmonary edema that can exacerbate the acute chest. But whilst we give fluids, we must monitor the intake and output so that, as I said, we don't cause overload. It is important to do this, especially in children, to look at their weights almost every day to make sure that if they are increasing in weights, you must be sure that probably you are infusing them too much. Pain management is a key in the treatment of acute chest syndrome. And we must rapidly initiate pain management, usually assessing the pain first and grading the pain before you decide on what to use. By using the WHO ladder for pain relief, we're able to do this. So step 1, when we use paracetamol or the non-opiates. Step 2, we can step up. Step 3, we go to the strong opioids. But that is when we need to be careful so that we don't cause hypoventilation by way of respiratory depression. Blood transfusion is another key area you need to look at. But here, the goal of blood transfusion is to increase the HB level up to 10 and no more. So if the patient has a low HB, then you would try and do a simple blood transfusion, raising the HB not more than 10 grams per deciliter. Because in acute chest, it is known that HB levels can fall and fall very fast, and so we need to be watching them. As I said, we can use simple transfusion or exchange blood transfusion, which is usually reserved for very severe cases. And also patients with a higher HB level, 12, 13, 14, 15, because this high HB levels is a risk for hyperviscosity and therefore leading to sickling and all the other complications following. People with a rapid progression of acute chest, as manifested by a decreasing oxygen saturation or anything below 90%, when you are even offering supplemental oxygen, may require exchange blood transfusion. And so people with increasing respiratory distress, progressive pulmonary infiltrates, and declining HB, these should be offered exchange blood transfusion. We said infections play a crucial role in the causation of acute chest, and therefore antibiotic therapy is key. So broad spectrum antibiotics, after we have taken samples for culture and all that, we should think of atypical organisms like chlamydia and others. And so we should give antibiotics that will cover for such organisms. We know that in sickle cell disease, yesterday we were told that the encapsulated bacteria, Haemophilus influenza, and strep pneumo are key organisms, but there can be staphylococcus, there can be chlamydia, and other organisms that we need to take care of in sickle cell patients. In adults, some people recommend that you can do prophylactic thromboprophylaxis. I'm a pediatrician, so I won't go in there. When we are managing patients with acute chest, we should monitor them very well. Monitoring is key. Otherwise, if you go to bed, things may get worse without you knowing. So we need to monitor vital signs judiciously. And this should include a continuous monitoring of the oxygen saturation. And as we said, if oxygen saturation decreases, then even ICU care can be invoked. We need to monitor the temperature of the patient. We need to monitor the pulse rate, the blood pressure, the respiratory rate. If all these things are becoming a problem, then it means that the condition is getting worse, and therefore we need to do something. A daily chest examination should always be done. I would even recommend twice daily chest examination. And as we said, we need to watch the HB level. We must get the patients to expand their chests by way of incentive spirometry, blowing balloons. We know that the spirometer are not, as it were, available in most of our facilities in our sub-region. But the ordinary balloon can be used for, especially in children, to blow out this thing, to expand the alveoli so that there's no atelectasis formation in there. Management of acute chest, all we are doing is to save lives. And so by way of prognosis, we have said it is a dangerous complication, has a high mortality, and therefore we must watch out. And the speed and timely intervention that we put in can give a good patient outcome. And so early recognition and treatment are very, very important in acute chest. Can we prevent acute chest syndrome in patients? Yes, there are some few things we can do. We have said that the initial problem is with sickling. And therefore, if there are things that we can do to prevent sickling, then we can also prevent acute chest. So if we can prevent infections by routine vaccinations, yesterday we heard about that. If we can prevent precipitants or things that precipitate pain episodes, then acute chest could also be prevented. Hydroxyurea, that we know do good things for sickle cell patients, is one way of reducing sickling episodes and therefore preventing acute chest syndrome. So we should be engaging our patients to be using hydroxyurea. It's also thought that therapeutics that are using anti-inflammatory or anti-polymerization medications are a new approach to preventing worst scenarios. Respiratory failure would be the end point for acute chest syndrome for patients to kick the bucket. Pulmonary infarction is another complication that could result from acute chest. Pulmonary fibrosis, because as I said earlier, that acute chest could injure the lung parenchyma. Therefore, it can lead to pulmonary fibrosis, leading to impaired lung function and others. And that could result in pulmonary hypertension as well, especially in the adults. Pleural effusion has been stated as one of the complications that attend to acute chest. And of course, eventually death if we don't do things right. So what could be some of the key points to take away as we conclude this talk? We have mentioned that acute chest is one of the critical life-threatening complications of sickle cell disease. The complication that occurs specifically in the lungs or in the pulmonary system, that usually come from the sickling process. So it requires prompt recognition and intervention, as we have enumerated earlier. And a comprehensive care is essential for optimal outcome. And here I'll recommend that as pediatricians or adults treating patients with sickle cell disease, collaboration is very important. So multidisciplinary approach to the management of the patient with acute chest is important. So if there's a pulmonologist, if there's a physiotherapist, especially chest physiotherapist and all that, we should bring all these people on board. If there's a hematologist, because of blood transfusions, you bring all these people on board in managing the patient. And lastly, there can be preventive strategies, especially the use of hydroxyurea and vaccinations for our patients. These are very critical things that if we do, we will be able to, as it were, save our patients with acute chest syndrome so that we can keep them alive as we want. So on that note, I want to thank you for your attention. These are some references that I have used in this presentation. Thank you very much. And
thank you very much, Professor Alex. Thank you for an excellently well-delivered lecture. Thank you very much.
thank you.
We would take questions, but before we do, just permit me to quickly acknowledge that one of our participants is Professor Song, one of the foremost elders in hematology. And we also have Professor Salah, a former provost of our college, College of Health Sciences, University of Abuja, who is also a member of the Technical Advisory Committee of the SPATRAIN. So we'll take questions, and while you can raise your hand to ask a question, while we're doing that, let me just read out one that was already posted on the chat. Professor Alex, so there's a question here that says that being that some sickle cell anemia patients have low baseline SpO2. How do we make use of SpO2 reading in suspected cases of acute chest syndrome?
Okay, thank you for the question. In sickle cell disease, many of the management interventions that we require to give our patients would have to be looked at in perspective of the patient's baseline, as this question suggests. For example, if you want to define acute sequestration crisis, they will tell you that a drop of HB level 2 grams per deciliter or more from the baseline. Even in the definition of acute chest, they said that the presence of a new infiltrate. So that suggests that you know of what was happening already. So those with a low baseline, I'm sure when they have acute chest, they are going to go down further. And so if you have a baseline, which will be, let's say they are normal, if they come and there's a decline in the baseline of the SpO2 readings, then it could be your suspicion might be heightened in this patient. And of course, you also need to, as it were, apply all the other things that we've mentioned, the signs and symptoms that the patient may present with. And so this is what I will say to this question. Thank you.
Thank you very much. I can see Maduka Collins, your hand is up. Please, can you unmute yourself and ask your question?
Okay, thank you very much for this presentation, sir. Please, I would like to know if acute chest syndrome is resulting from fat embolism. Is there really specific protocol for this for management of acute chest syndrome resulting from fat embolism? Thank you.
Acute chest from fat embolism is usually, for us in the sub-region, is usually a difficult area in terms of diagnosis and all that, because you need to do what is called bronchoalveolar lavage and see the fat emboli in the cells. And in one literature I read, it said that most cases of fat embolism that occurs in acute chest, the diagnosis is even made post-mortem. So it becomes a very difficult area to deal with. Just that we would need to do what we need to do right in terms of managing the patient as a total patient with acute chest syndrome, and not looking at trying to, as it were, deal with the fat embolism, because after all, in many of our centers, we cannot even make the diagnosis anyway in the first instance. So I would say that even if it is fat embolism causing the acute chest, we should treat the patient as we have gone through, because there will be no specific treatment in terms of the fat embolization, apart from controlling the pain and the sickling process that led to the fat embolization. Thank you. I hope I've been able to answer your question.
Okay, so there's another hand up, Dr. Adama. Please unmute yourself and ask.
Thank you very much, Professor Alex, for that wonderful presentation. I just want to make two contributions to that presentation. In the literature, we notice that we have low data of ACS amongst our patients here in sub-Saharan Africa. So I think this lecture is quite timely, and I think this calls also have to have high vigilance. And I think basic thing, like just any patient that comes into admission with crisis above the diaphragm, the chest, the back, we should have that high vigilance, simple measures like using pulse oximeter to check oxygen saturation on daily rounds. I think all those simple measures we go a long way for us identifying patients who come with this very critical condition. And the other, I just want to respond to the issue about thromboprophylaxis as adult hematologists. I think Professor Alex said he's a pediatrician, so he did not say much about that. So what I want to say is sickle cell in itself, they've got a high prevalence of thrombosis. The prevalence of PE, especially in sickle cell, is about 11%. So I think the practice is when they come in for admission already, that increases their risk because they are acutely unwell, which increases the risk of thrombosis. They are hospitalized, they are immobilized. So the role of giving prophylactic enoxaparin, maybe 40 milligram daily, becomes very, very important in that setting. This also acts as a preventive measure for acute chest syndrome. And then in the event of pulmonary embolism, so you're trying to kill two birds with one stone, so to say. So I think the practical approach or practice should be to give enoxaparin if the patient can afford it. Unfortunately, it's quite expensive in this region. But I think by the time we look at the consequence of not acting for a patient that is at risk of ACS and PE, then the cost of giving prophylaxis becomes, less. So those are the two contributions I want to make. Thank you.
Thank you very much, Dr. Adama, for this contribution. Very timely. That is why it is important to, as it were, do collaborative work and multidisciplinary work in the management of our patients, as I said earlier. Thank you very much.
Thank you very much. I don't see any other hand up. And I don't think I can see any questions on the chat. Once again, we want to thank you, Professor Alex, for your wonderful presentation. And we're going to move on now to the next topic for the day, which will be presented by Dr. Teka Atim. He's of the Department of Surgery, Urology Unit, University of Abuja, and University of Abuja Teaching Hospital. Dr. Atim is an associate professor of urology. Dr. Atim, you can go ahead to share your slides and start your presentation.
Thank you. Thank you very much, Professor Maxwell. Am I audible?
Yes, you are, but your slides are not on slideshow. Okay, it's there now.
Yeah, I just put them on slideshow. So good morning to everyone who is on the call. I am privileged to also be on this meeting to deliver this talk on priapism. I've been rightly introduced by Professor Maxwell. I'm Teka Atim. I'm a urologist and an associate professor with the University of Abuja. I would take this presentation using this outline as shared. First and foremost, it's important that, as the earlier presenter has stated and as the other presenter stated, that this problem requires a multidisciplinary approach, and the meeting is an MDT workshop. So I appreciate that fact, and the more we encourage and embrace multidisciplinary attention to our patients, the better I believe we'll have outcomes that are favorable for the patient. Now, what is priapism, which is the topic to take this morning? Priapism is a prolonged erection penis which is unrelated to sexual stimuli, lasting more than 4 hours. It's usually a painful, prolonged erection, but for the general definition, we won't put pain here yet because there are some types of priapism that don't come with pain. It's typically a urological emergency and has to be treated as such. The management of priapism aims at 1, preventing penile disfigurement or shortening, which comes as a result of the ensuing fibrosis that happens within the cavernosal tissue of the penis. also in trying to prevent erectile dysfunction, which is the biggest sequelae that patients would not want to have. Then the psychological problems that come with priapism as well, whether there are issues that happen and the patients are embarrassed and even don't even want to come to hospital to present with such a thing like priapism. There's a rare type of priapism which can also affect women, that is priapism of the clitoris. And this has been described in children as well. Now, the term priapism comes from, was derived from the Greek god, name was Priapos, and he's been worshipped as the god of fertility. And for him testing his sexual prowess, he chose to, in this picture, weigh, his phallus against a large bag of coins. So the name priapism or the term priapism is derived from this Greek god called Priapos. What's the overall incidence of priapism in males? It's said to be 0.3 to 1.5 per 100,000 per annum. Now, men in their 5th decade worldwide are most commonly or most frequently affected. This is so because if we look at the entire picture of priapism, usually in the Western world, the commonest problems are people who are using drugs for erectile dysfunction. So at times they get an overdose either with the tablets or the injectables, and then commonly present with priapism. But our problem is in pediatric priapism, and this has largely been underreported. And again, it has to do with the issue of embarrassment, either for the young boy or even the parents of this young boy bringing him to the hospital that he's having an erection, and the erection is lasting this long. So because of that, there's been thought to be underreporting of pediatric of cases of priapism in children. Again, the incidence of childhood priapism would vary depending on one's location. In areas where diseases like sickle cell disease or anemia is prevalent, there tends to be a higher incidence of pediatric priapism, whereas in places that this disease is not very common, you may hardly come across priapism in children. Of course, the issue of definition of priapism in terms of the timing. So some literature will put it at 3 hours, some may push it up to like 6 hours, but most guidelines use 4 hours. So if we vary these definitions based on timing, you may also have different incidents of pediatric priapism. In our environment in Africa, sickle cell disease is the commonest cause of priapism. And Adeoju et al. And our study also in the University of Abuja Teaching Hospital had alluded to the same conclusion. A brief anatomy. The penis is a male sexual organ, and it's tubular in nature. It's got 2 cylindrical structures called the corpus cavernosum, and they look like honeycomb. They've got air-filled spaces in them. These are actually the cavernosal smooth muscles, and this appearance is very important for the production of an erection. Now, there's a 3rd tube, which is also cylindrical, that conveys the urethra, and that helps the male organ in emptying both urine and semen. Now, the penis is supplied by blood vessels, and it also has its innervation. The blood vessels or the blood supply that is important for our anatomical discussion this morning would be the deep penile artery, which takes blood to the corpora cavernosum. They're also known as the cavernosal arteries, and these arteries pump blood into the spongy tissue of the cavernosum. Then there are also the venules which empty the blood that has been pumped into the corpora cavernosum. So once the erection is done with, the spongy tissue of the cavernosum is supposed to now empty, the blood through the veins and back into the general circulation. The 3 cylindrical structures are encased by a top fascia called the box fascia, as well as the tunica albuginea. Now, this tunica albuginea gives some resistance that helps the penis to remain rigid once it's filled with blood. At the point that the erection is done with, there's supposed to be now relaxation, or rather contraction of the smooth muscles of the corpora cavernosum, and then emptying of the honeycomb spaces of this blood. Now, when we look at the physiology of erection, the normal erection is initiated by, could be genital stimulation, either by touch, or audiovisual stimulation, and this would trigger a normal erectile process in the male. There's also the central stimulation and then the central origination stimulation. Penile flaccidity is maintained by high resting cavernosal smooth muscle tone. Now, when the smooth muscles of the cavernosum are in the high resting tone, that is, the smooth muscles are relaxed, it allows for blood to flow in. But when the tone is increased, then they contract, they now prevent blood coming in and rather encourage blood from leaving the penis, and that leads to penile flaccidity. The normal erectile process has different phases. There's a latent phase of erection, there's a tumescent, full erection phase, and the rigid erection phase. There are several pathways that, at the end of the day, bring about erection. We've got the parasympathetic innervation pathway, which leads to stimulation and production of nitric oxide. Now, nitric oxide is very pivotal in producing an erection. So the parasympathetic pathway usually will lead to an erection, whereas the sympathetic pathway causes the release of noradrenaline, works through the phosphodiesterase enzyme to eventually cause flaccidity or detumescence of the penis. There are also hormones like testosterone, especially, that are also of use in the interplay of erection and detumescence. Now, what goes wrong in priapism? If you look at this, this depiction of what happens in a normal erection and in the abnormal erection here, so-called priapism, the problem is usually with the phosphodiesterase 5 enzyme. Like I said, normal erection would happen when there's a parasympathetic pathway that leads to the erection through the effect of the nitric oxide. At the end of the normal erection, there's supposed to be a break point where the penis should return to its flaccid state. And the phosphodiesterase enzyme is what is responsible for breaking the erection cycle and returning the man to, or the boy, to flaccidity. However, in patients that have priapism, there is a break at the point where the phosphodiesterase 5 enzyme should break that cycle. So we have a persistence of the erection, and that is usually not good because it could cause ischemia, as we are going to find subsequently. Again, this is just a picture of what happens in the erection. You see this red honeycomb appearance within the corpora cavernosum. Now, this gets filled up with blood when there's an erection, and once the erection cycle is broken by 5 PDE5 inhibitor, then the honeycomb should empty. The cavernosal vessels should now empty and become, the penis now becomes flaccid. There are different types of priapism. And as we look at these different types, it will also enable us to understand the physiology behind each of them, and later on how we can also manage each of these situations. The first and most troublesome and most problematic is the ischemic or low flow, also known as veno-occlusive priapism. Now, so this is a prolonged, usually painful erection of the penis, lasting 4 hours or more, and is typically associated with ischemia of the corpora cavernosa. Now, that is again the type that is commonly found in sickle cell disease patients. The second type of priapism is a non-ischemic or high flow or arterial priapism. This is equally a prolonged erection of the penis lasting 4 hours or more. But the good news is this is not associated with ischemia. So the problems that would have happened because of ischemia are not found in a non-ischemic type of priapism. We also have this other interesting type of priapism called the stuttering priapism. Again, something that we see a lot in sickle cell disease patients. And the stuttering priapism is also known as an intermittent or recurrent ischemic priapism. These episodes of recurrence and priapism are usually self-limiting, but they may be prolonged, and it is at best managed as cases of ischemic priapism. So stuttering priapism is actually a form of ischemic priapism that is usually seen in sickle disease patients. Now, the first three are broadly the three types of priapisms that we see. The last one is an entity that is quite rare, neonatal priapism. And this, again, usually has good prognosis, and again, is something that is self-limiting. You may not really do anything for this category of patients. It's prolonged erections that are seen lasting hours in newborn babies. We'll look at each of these individually and then go down to how to manage these cases and treat them. Ischemic priapism, the human classic theory of congestion and swelling of the bloodstream, is the theory that underlies ischemic priapism. We've said that the cavernosa smooth muscles, after they get filled up with blood, there should be a period not lasting longer than 4 hours that this blood that has filled up has become congested in the penis should egress. If the blood stays there for longer than 4 hours, then necrosis would start in the cavernosal tissue. And if necrosis persists by the 48-hour, that's about 2 days' time, the cavernosal tissue will start undergoing fibrosis. And this fibrosis is what will eventually lead to the shortening of the patient's penis. And by the time it's a child, when it grows up, will now have issues with erectile dysfunction. Sickle cell disease typically causes ischemic or stuttering priapism, but have also been associated with non-ischemic priapism, but that is a bit on the rare side. Usually it's the ischemic priapism that we see in sickle disease patients. How does this happen with sickle cell disease? The deoxygenated hemoglobin, like we have learned from this, or we've been reminded of in this workshop, causes sickling. And these sickle cells have a problem with, obstructing the microvasculature and causing ischemia down the road. Sickling itself also causes or stimulates hemolysis. And it's been said that free hemoglobin in circulation is not good for the nitric oxide that is pivotal in the erectile process in men. Now, the decreased nitric oxide availability also decreases the PDE5, which is the enzyme that breaks an erection process. So that, in other words, keeps the penis in a rigid state or in an erect state beyond a period of time that is safe for the cavernosal tissue. For stuttering priapism, sickle cell is again the commonest cause of this type of priapism. And the etiology, like we said, is akin to what happens in ischemic priapism. There are many pathways that can, lead to stuttering priapism. And one of them, again, is just what we've discussed with the cavernosal smooth muscles in ischemic priapism. The other ones are basically things that have to do with some growth factor regulations and the central neurological control systems. Non-ischemic priapism usually happens because of trauma. And like I said, in this instance, since there is no ischemia, prognosis is usually good. And the patient may even have these problems limiting itself with time. At times, you may need to perform surgery on them. The onset of this type of priapism is usually delayed by a few days following trauma. And that is usually because initially after trauma, the process of hemostasis would come in. So the fistula or the injured vessel might get clogged with a blood clot. And then with time, when it gets opened up, then the penis or the blood flow now rushes into the penis and causes the non-ischemic form of priapism, also known as arterial or high flow priapism. This is actually common, another form of an intravenous fistula, AV fistula formation that can present this way. Neonatal priapism, I've said it's usually a benign thing in newborn babies. It is important to note, however, that sickle cell disease is not associated with neonatal priapism. And this is because these newborn babies have the presence of fetal hemoglobin, which is protective against sickling, and it helps them not to get into this form of, to have the ischemic form of priapism. So this has not been reported, ischemic priapism has not been reported in neonates. The neonatal priapism on its own is usually a priapism that has good prognosis, has a benign pathway. Full recovery is expected from this category of patients. What are the common causes of priapism? Generally speaking, again, blood flow anomalies, which could be of traumatic origin, either an AV fistula formation or trauma that leads to some disruption of the arterial blood flow to the penis. There could be neurotransmitter imbalance. We've talked of so many neurotransmitters under our pathophysiology, nitric oxide, PDE5 inhibitor or PDE5 enzyme. We can also have underlying health conditions. Many of them, especially the hemoglobinopathies, can form a common cause of priapism. We also have some blood malignancies, leukemias. All of these are causes of priapism. Medications, especially drugs that are used for treating erectile dysfunction, drugs that are also used in treating, in psychiatry, psychotropic drugs can also lead to priapism. At times, even substance abuse, people that take drugs, substance abuse, things like marijuana, cocaine, and so they are prone to having priapism. Infections, rarely, but they can happen. Trauma, mentioned some of these cases. Surgical procedures. So some surgical procedures, especially spinal cord procedures, can give rise to priapism. But if we're looking at ischemic priapism, which is common in sickle cell disease patients, we'll know that the sickle cell itself is the commonest cause of priapism in children, and this has been alluded to by some researchers. Adeogo in his group realized that up to 65% of the cases of ischemic priapism in their multi-center study were attributable to sickle cell disease. And this was followed by trauma and the idiopathic causes, and then leukemia, and 5% accounted for by drugs. In the University of Abuja Teaching Hospital, we also did a survey and realized we had as high as 85%, 82% of cases of ischemic priapism being attributable to sickle cell disease. Leukemia, substance abuse, marijuana was detected in a couple of patients, and then clozapine, which is an antipsychotic agent, was also implicated in ischemic priapism at our center. Now, how do we make a diagnosis of priapism? We must go back to taking, a detailed history from this patient, and it's important to mark and document the onset of the problem and the duration of the problem, because this would help you know where in the management line, when you come to treatment, which options of treatment will be applicable for this patient based on the time the patient has come to the hospital with. Now, we realize there's a bimodal age incidence for ischemic priapism in our center. usually the prepubertal age group. We found it common in the prepubertal age group, and then in those post-adolescent age. Now that reflection was seen in University of Abuja Teaching Hospital. So 0 to 12 years, we had a high incidence, and then those above 18, we also had a peak in this category of patients. It's important to find out if the erection is associated with pain. Pain would help us narrow down the priapism to an ischemic type, because like we said, the arterial or high flow priapism is not painful. So we must ask if the erection is painful or not painful. Then are there things that would have been found in the history to be contributing to this priapism? We talked of maybe usage of drugs, looking out for other underlying illnesses like leukemia and so on. When we examine the young patient or the man with priapism, we want to assess how rigid the erection is. So, because if you look at the physiology, we talked of different phases of rigidity. There's full rigidity, there's skeletal rigidity. You want to document how rigid the erection is. Is there or could there be associated swelling, which would be a sign of, the ischemia worsening and getting to the point of necrosis? Then any signs of tissue damage. All of this should be documented when we evaluate these people with priapism. Blood gas analysis usually would give away the correct diagnosis. How do we get this? We stick in a needle in the erect penis, take blood sample, and then determine the oxygen and pH levels in the blood of that erect penis. For ischemic priapism, of course, the oxygen level will be very low. pH is going to be also very low because of the acidotic changes that would have started occurring. While for the high flow or the arterial priapism, the oxygen levels would still be normal and you may still maintain a normal pH. Doppler ultrasound scans are useful, and this again helps when there is a huge conflict between trying to decide whether it's ischemic or non-ischemic. We may need the expertise of a radiologist who will do a Doppler ultrasound of the penis. In the ischemic priapism, the low flow priapism, there's going to be poor blood flow into the penis, and that is bad. That's not good. While in the high flow or the arterial priapism, the Doppler study will still reveal a normal blood flow. There are some precipitants of priapism in children with sickle cell disease. So things like nocturnal erections, sexual activity, dehydration, fever, and exposure to cold may be precipitants of priapism in children with sickle cell disease. Treatment. Now, this should be done by experienced clinicians and in a timely manner. Remember, we've said this is a urologic emergency, so time is of the essence in treating patients with priapism, especially ischemic or stuttering priapism, which is common in sickle cell disease patients. It is not something that should be treated without thinking of the timelines that eventually would mean that the patient's prognosis has been worsened by the first responding clinicians. So we've had instances where patients are kept with priapism and the clinicians are treating with sedatives, diazepam, and all of that. And by the time it doesn't resolve, of course, it's not going to resolve, they're now sending the patients to the expert to treat, and by then, damage has already been done. The initial management aims at first trying to define what type of priapism it is, and then to immediately try to achieve detumescence, that is to return the penis to a flaccid state. The use of analgesia is important because these patients are usually in very, very painful condition, especially when it is a ischemic type. First aid measures could be given, and this may even be taught to parents or these children. Things like engaging in physical exercises when the suspect an erection is lasting longer than usual, running up the stairs, asking them to empty their bladder, have a cold bath, and then for those who are at the age of point of even being able to ejaculate. That may also help to relieve the ischemic priapism. Then fluid use, rehydration, when these patients are properly rehydrated orally, it could also assist in taking care of the initial or delaying the progress of this problem. Ice packs. Cold packs have both analgesic and cytoprotective effects. So because they cause vasoconstriction and decrease renal blood flow. But this should be said with caution because these cold packs are not to be used for priapism or ischemic priapism from sickle cell disease. So this is not for sickle cell disease patients who are having priapism. But other boys or men with priapism from other causes, either they've taken a drug for erectile dysfunction and develop priapism, cold packs have a role to play and in slowing down the ischemic process. When the problem persists, of course, one should endeavor to rule out hemoglobinopathies, which should come up very top in our environment because most patients with priapism, sickle cell disease is in the background. So we must always make out room to investigate and exclude hemoglobinopathies in our environment. We can use drugs to manage ischemic priapism. This includes phenylephrine. This can be injected directly into the penis. And if you are lucky, the response is quite spontaneous and very impressive. If the injection doesn't work, one could go ahead and aspirate the penis. So this is like deoxygenated blood. Once you stick in a needle and you aspirate, you're going to see that the blood is dark and tarry. This is blood that is clearly deoxygenated and should be gotten out. So you keep aspirating until the penis returns to a flaccid state. Exchange blood transfusion has been mentioned earlier by other presenters, especially patients with sickle cell disease. This is a very, very pragmatic way of also addressing this problem. Now, for surgery, it gets to a point the patient would need surgical assistance. So we can help these patients by doing surgical procedures like putting a shunt or creating a shunt. This shunt would help to route the blood away from the penis so that ischemia doesn't persist. Pain management, again, has been addressed, so I won't dwell more on that. In the long term, these patients should continue having their follow-up to monitor recovery and to see if one is able to prevent the future occurrences as well as complications like erectile dysfunction. Psychological support. We've talked of issues of embarrassment, a young child who is in school always having, an erection that is painful and his peers will be wondering what's wrong with him. So these patients would need a lot of psychological support. The parents as well will need to be supported, counseled, and, reassured that this is a common occurrence in patients with some particular disease conditions like sickle cell. Lifestyle changes. If there are triggers or precipitating factors that have been identified, it would be wise to counsel against such. For instance, substance abuse might be helpful to tell these patients that, this is what is responsible for their having priapism. So it's better they prevent such, and they should also have the desire to always have a quick hospital check whenever they're having an erection that is lasting longer than necessary. Now, these are some of the surgical interventions that can be given even in the emergency room. You don't need to always go to theater. The first line surgical attention is to keep drawing blood from the corpus cavernosum. So one could stick in a scalp vein needle into the corpora cavernosum and then draw up the blood, which, like I said, will look dark, just the oxygenated blood. That alone might solve the problem. In instances where the patient didn't come early, the blood in the corpus cavernosum must have started forming clots. So you might need to also irrigate the corpus cavernosum. So as you aspirate, you also push in saline to wash out the clotted blood from this patient's cavernosum. Then, of course, we can also inject alpha agonists, like I said, phenylephrine can be injected into the corpus cavernosum to help allow vasoconstriction and then allow egress of blood back into circulation. These procedures, like I've said, have very high success rates. If simple aspiration, irrigation, and injection of drugs don't work, then the second line treatment options now have to come to play. And this would require the surgeon creating a shunt. So this now moves to a proper theater setting where the doctor, usually a urologist, will have to create a shunt. We'll look at some shunts in the next slide. There's also this concept of putting in penile prosthesis in the older patients. These are usually for adults who are sexually active, because if one has the knowledge that the patient has a very high chance of developing erectile dysfunction, and it's going to be difficult to manage such a patient because there's going to be fibrosis. So there's typically very poor prognosis for that man having erections. It might be better to put in a penile prosthesis at an earlier date. Again, if the penile prosthesis is to be inserted, it's easier when there's less fibrosis, when the fibrosis has not become so much. So it's better to do these surgeries earlier in the presentation. So these are some of the shunt procedures that can be done by the surgeon to reroute blood that is collecting. One just creates an opening in the two rods that have the corpus cavernosum. So the blood, instead of collecting here and increasing the tension and ischemia, egresses out and follows the glands back through the spongiosa, the corpus spongiosum, into the circulation. So these are distal shunts. This is also a distal shunt. At times, one now has to do a proximal shunt if the distal shunt fails to resolve the process. The proximal shunt may require getting a saphenous vein, like they are doing in the picture to the extreme, dissect the saphenous vein and then anastomose it to the corpora. So the blood goes through another route back into circulation. We've talked of early prosthesis. Like I've said, in adults, if the presentation is more than 48 hours, ED is deemed inevitable. So it's better to think of the man's future career, because he's not going to have erections. So if you put in an implant, it helps. Now, this is a picture of an implant that is being inserted here in this patient. So they are just rods that are controlled with a pump that can be hidden in the testis. So once you activate the pump, these rods that are buried in the corpus cavernosum become filled up with fluid, which is what now gives the man an erection. Where this is a problem might be children, because you cannot, there are a lot of ethical issues and there may be medical legal problems with using implants in children, but this is something that can be done for adults. In neonates, priapism, like I said, prognosis is good. One might just need to do a Doppler ultrasound quickly to ascertain that it is purely a high flow and not an ischemic process that would jeopardize the corporal tissue in this patient. At the most, maybe a corporal aspiration could be done. So you just stick in a needle and draw out the blood. Ketamine anesthesia has been thought to also be useful. For some babies, it might be, again, a manifestation of polycythemia. So if one does a venous section or phlebotomy, that might help resolve the problem. We should take note, though, that we don't usually advise giving corporal injections or doing any of these shunt procedures in the neonates. Again, like I said, prognosis is typically good. For stuttering priapism, we are to manage this as we manage the ischemic priapism. So it is an emergency as well. You do everything you need to do to break the cycle of erection and return the penis to its flaccid state. Because it's a recurrent and intermittent kind of priapism, some drugs have been tried. So things like ephedrine given at night to these patients may reduce the episodes. Hydroxyurea has also been talked a lot about in this presentation, in this workshop. So it's also useful when we give hydroxyurea to this patient. It reduces the frequency of stuttering priapism. Things like baclofen, which is a drug that works, has a neuronal basis of its mechanism of action, can also be used to prevent or reduce the episodes of stuttering priapism. I'll move quickly because I think I'm running out of time. For the non-ischemic priapism, management, like I said, is not urgent. This is high flow priapism. So it's even good. There's enough blood going there, just that it's not being regulated. Children, it may just be a telltale sign of spinal trauma in children. That is non-ischemic priapism. Now we manage this type of priapism conservatively or mechanically by using cold compress. One could also give drugs. You could have radiological interventions, like embolization. If one can discover the fistulous vessel, then we could use radiological means to occlude such vessels, either with gel form or autologous blood clot. Surgical ligation is the extreme of treatment, where the surgeon goes to clip or to identify the vessel that is leaking, and then he ties it up. Now, I leave very shortly, but here's an algorithm for managing patients with priapism. And the first thing is for us to take our time to get a good history, document the time the problem started and the time the patient is presenting, to be able to find out again from our evaluation whether it is a stuttering priapism, whether it's an ischemic priapism or a non-ischemic priapism. So when we do this, we're able to now go down the cascade of events that we should do and manage those that require just conservative management, those that need to be given quick attention, emergency attention, so that they don't develop more corporal ischemia and necrosis and fibrosis. Then complications. The most important complication is erectile dysfunction. And this, in a lifetime of a patient with sickle cell disease, is as high as 30% or more. Now, the ischemic priapism, of course, can also cause other problems to the patient, such as anxiety, and then his aversion towards sexual behavior, because he's now worried that each time he has an erection, it's not a good thing. Prognosis is better when these patients are treated early. Once the penis remains erect for up to 12 hours, interstitial edema has already set in, and by 48 hours, necrosis has already occurred, and this is irreversible. The sequelae is definitely going to be fibrosis. So we don't want to leave these patients late or to get them late at the point where we already know that there is a problem with their corporal tissue. Rapid resolution of ischemic priapism prevents permanent cavernosa structural damage and is associated with improved prognosis for potency, that's for erectile function in later life. By way of conclusion and take home, priapism, especially the ischemic type, is a urological emergency and should always be treated as such. If it is left unattended to, it leads to necrosis, fibrosis, and invariably future erectile dysfunction. Sickle cell disease is a common cause of ischemic priapism in our environment. Now, whereas hematological or systemic disorders precipitate ischemic priapism, their treatment should not preclude or delay corporal measures to reduce the child's priapic episode. Timely assessment, like I've emphasized in this presentation by clinicians, and intervention is advocated for us to have a good outcome. Thank you very much for your attention. These are some of my references. Thank you.
Thank you very much. Thank you very much, Dr. Atim, for your detailed presentation. So we're going to take a few questions, and then we move on to the next one. So if you have any questions, you can raise your hand. I can already see Dr. Adama, you have a question. Please unmute yourself and ask your question or clarification.
Thank you, Professor Atim, for that wonderful presentation. I have some few contributions to make. I think his presentation emphasizes the importance of having a joint management with both medical and surgical. And I think it's important that we try as much as possible to optimize medical management so that we don't have to, we try to avoid the surgical part of things until it becomes very, very necessary. And also optimizing medical treatment means we try to prevent fibrosis, penile fibrosis, which at that point, there's nothing that can be done. So I just want to quickly add some point to what Prof has said. In terms of just having a high index in children, like children coming with daytime somnolence, or adults complaining of snoring. These are two things that may be associated with nocturnal hypoxia. And we know that these are, once you have nocturnal hypoxia, what happens is you tend to have ongoing vaso-occlusive crisis, and that may tend to worsen. It may precipitate or even worsen priapism. So simple measures as trying to, address why they have daytime somnolence, managing it, or simple measures like if somebody has got an enlarged tonsil that is causing snoring, just the removal of that tonsil, improving their nighttime oxygenation may all add up to improving their episode of priapism. And the other thing I want to add in terms of medical treatment, I think the first line treatment, epinephrine, ephedrine, we may not have this commonly available in our own center, but if it's available, I think it's good to start with those first line because they've been shown to, most patients that are very compliant with such first line management, they tell you that except when they stop taking them, that's when they have episode, but once they are compliant, they tend to be free from priapism. But in our environment, there's a recent study from AKTH, which I think is something that we should all key into. And this is where they combine hydroxyurea and tadalafil. And the importance of combining these two is we know hydroxyurea is a second line treatment for priapism. But once you have tadalafil, the advantage there is, in addition to just having priapism, one of the complications is erectile dysfunction. So it tends to have, it helps with the priapism, and then it also helps with the erectile dysfunction. So I think it's good to adapt to what we have in the environment. So let's maximize hydroxyurea, let's maximize tadalafil. In centers where they can do apheresis, red cell exchange is very, very effective. I know of a patient who says once he's on regular red cell exchange, the priapism tends to be better. But what happens is around 5 weeks, once the effect of the apheresis is beginning to wear off, then it begins to have episodes of priapism. So it tells you that trying to reduce the amount of sickle red cell makes a lot of difference. So that's where we can actually hold on to hydroxyurea and then red cell exchange if possible, and then look at the literature and from the work AKTH has done on tadalafil. I think it's very, very good. And then the last thing I also want to add, just to also highlight that if you have epinephrine or ephedrine available in your center and patient are on that, keep an eye on side effect, because one of the reasons why patients, even if they can afford it, they stop to use it is because of the side effect that are associated with this treatment. So they may have a raised blood pressure, they may have fast heart rate. So all this, and these are things that you have to preempt them before they start taking it. And then lastly, Prof mentioned about some behaviors like emptying their bladder before they go to bed. These are small things, but they all add up. Usually we say for exercise, ask the patient to run up the stairs. I think another alternative if they don't have a stair is they can run about. A patient said to us, are you trying to tell me when I have a practice in the night, I should go about running in the night? So I think sometimes when we give the advice about exercise, give something that is reasonable, something that is realistic. So one exercise that has been shown to be effective is press up. It's even more effective than asking the patient to be running about in the night. So if you can ask the patient, once you have something like that, make sure you empty your bladder. But if you think it's coming up, you can do press up in your room, and that hopefully that will help. Because in this cold weather, and I ask somebody to have a cold shower, they may be skeptical about that. So sometimes let's look at what is realistic, what is feasible, and try to advise them. But I want to end by saying we cannot overemphasize the importance of having joint, management of this patient with the urology. And that's why we have this beautiful presentation. So thank you very much. That's my own contribution.
Thank you, Dr. Adama. Thank you for that. There are some questions on the chat, Dr. Atin. So if you don't mind, let me just quickly read them out.
Okay.
One is, Is there a reason why the frequency of priapism is lower in teenagers within the age bracket of 13 to 17 compared to those within 0 to 12 years of age?
Okay, thank you. I'd like to thank Adama especially for the contributions she just made, and very useful contributions as that. We try to look at our environment and see what's applicable to us in advising and counseling patients. So that is very, very impressive. Yes, and the fact that tadalafil or sildenafil and hydroxyurea, excellent contribution as well. Again, it sounds paradoxical, but that is the truth. You know, using tadalafil, which is a drug that we use to achieve erection, and giving it to somebody that has a tendency to having priapism. But that is purely what it does. It improves oxygenation to the penis. It reduces the issues of necrosis and all of that. Yes, some of the drugs, like you said, that I mentioned are not in the environment, but you can quickly also make efforts to look for what we have. I'm aware some people have in the past tried Actifed as well for, drug that we use commonly for nasal congestion, and that works also at night. That is close to pseudoephedrine for patients with priapism, stuttering priapism especially. Somebody has mentioned salbutamol slow release. I guess that's something we should also look at. Now, with the question, yeah, this was a retrospective review, so we couldn't at that time, try to think about the reasons why we had a bimodal picture of priapism in patients with sickle cell disease. But I would say that it's been reproducible, so probably we'll need more research to find out if there's something peculiar within those two extremes, the ones below 12 and then the ones above 18, why the incidence of priapism was higher in those two arms. So for now, I don't think I have a clear answer to why the 13 to 17 age range was had lower incidence of priapism in Abuja from that review.
Yeah.
Thank you.
Thank you very much, Dr. Atim. There are quite a number of questions in the chat. So I'm going to combine two now because it's from the same person, because we need to quickly address them and then go to the next lecture. He says, thank you for your presentation, robust priapism. I understand the classification, but worry about some criteria such as the presence of ischemia and 4 or more hours. We tell our patients to ensure to present to the ER by 3 hours, bearing in mind that there are naturally delays assessing care. Do we just assume ischemia because it's a person with sickle cell disease, or does pain serve as proof? And then there's also, I appreciate the association between nocturnal enuresis, nocturnal hypoxia, and priapism. Considering the role of nitric oxide deficiency, should administering NO by inhalation, a modality of medical treatment, be useful, just like sildenafil? I think you should address those ones, and then we.
Okay, thank you. The question on whether we should allow these patients wait till 4 hours before presentation, no. So the definition is if an erection has lasted longer than 4 hours, it's definitely priapism. But of course, if a patient has an erection which is lasting longer and has come to the ER, to your emergency department, I mean, it doesn't mean you can't have any interventions until it is 4 hours on the clock. What it means is things like we've talked of hydration, we've talked of certain first aid things that could be done to ensure that the erection is aborted. You could give an injection. We've talked of phenylephrine. Of course, it's quite difficult to have that in our environment. If you're giving adrenaline, you must have ECG monitors and all of that. So in the period before it gets to 4 hours, patient comes early, prognosis is very good. You can aspirate with a scalp vein needle or with a small syringe, a 2 ml syringe, the blue needle, and the patient gets flaccid, and that's all. So one doesn't have to wait until it's 4 hours. In fact, we encourage them to come earlier. Most people will say an erection lasts beyond 2 hours, in spite of all the first aid that one is given. Then that's the time to rush to the hospital. Then the other question on
inhalational nitric oxide.
Oh, I'm not aware of that being available, but that would be fantastic because, like I said, nitric oxide is also something that relaxes the smooth muscles of the cavernosum. So if it's available, I mean, and it's practicable to have it in an inhalational form, I mean, it's definitely going to be useful. Probably I would like some comments on that from someone who's experienced with inhalational nitric oxide. I mean, I haven't come across that. When we give tadalafil and sildenafil, it works by increasing nitric oxide in the cavernosal tissue. But for the inhalational form, I haven't come across it. So maybe if someone has, we'll be glad to hear from that person. Thank you.
Okay, so thank you very much. I think the one other comment here is like general, there are quite a number of experts here, hematologists, pediatricians, they could help with that. He said, please comment on priapism in female children with sickle cell disease. I've seen a total of 2 cases from our farm mostly. I guess that would be like general comments, people sharing experience, if there's anyone who has. But Dr. Tim, there's also one for you that says, can a general surgeon do the aspiration, or does it have to be done by a urologist? And whether one seed bath can be helpful in priapism as a first aid.
Okay, thank you. Yes, aspiration can be done by any doctor that is conversant with, that is supposed to be treating emergency situations. So it's not the job of a urologist. I guess it's when you step up to the second line therapies, either doing a shunt or doing penile prosthetic surgery, that urologist is clearly needed. So yes, any doctor, post-graduation, NYC, should be able to do aspiration. If you see in that picture, it's very easy. Just stick in a needle and use the 20 or maybe a 50 ml syringe and draw out the blood. At times, you even put in the needle and just put a kidney dish, and you keep seeing dark blood come out. You know we are okay when the blood starts getting bright red. Then you take out the needle, and by then the patient's penis goes flat. So aspiration is definitely not a highfalutin thing that we will say is restricted to the urologist.
Okay, so
then
thank you.
Okay, you talked of something like this, priapism in females, right? I haven't come across one. I've only read about it in literature. Again,
okay,
maybe
so thank you very much.
Hematologist.
There seems to be this thing about the contention between cold bath in ischemic priapism. Dr. Akinwumi posted it on the chat, as against a warm bath. Because she says, is a cold bath appropriate for an ischemic priapism venous, or a warm bath, which is what we recommend to children with a hope of achieving some vasodilation?
So ironically, for priapism or penile erection, what causes a penile erection is vasodilatation. I mean, you have blood that has gone into the penis that is now not able to come out. So that's what causes the erection and then the persistence of the erection. So the idea of the cold, using cold compress or cold bath, but mind you, I said in C class, we don't advise cold compress. Likewise, cold bath, not in C class. Priapism can occur from other causes. It's because you're trying to, if you use cold baths or cold compress, you cause vasoconstriction, not vasodilatation. So the inflow is reduced. So you're going to have more compartment syndrome in the penis if you reduce inflow of blood. Using warm water and warm baths, maybe for sick patients with sickle cell disease. Again, for the other types of vaso-occlusive crisis, I think it's fine. But for priapism, I'm not sure that would help for priapism, because you'd be rather causing more congestion in the penis. So I'm not sure about that, and we can think further and research about that again. Thank you.
Thank you very much. I think the last one I will leave you to look at it on the chat is from Augustine Benjamin, talking about the syndrome of Aspen, and you can just respond to the chat. Thank you very much, Dr. Atim, for this session. This has really been an engaging one. Please will move on because of time to the last presentation for the day. We have a presenter from Kumasi, Ghana. Once again, we are looking at Professor Fred Safo, who's done quite a lot of work on stroke. So he will be talking to us about acute stroke in sickle cell disease. Professor Safo, you're welcome. You can go ahead to have your presentation.
All right. Good morning, colleagues, and thank you very much for the kind introduction. Please, I wanted to find out, is my slide visible? And am I audible?
Yes, you are, both.
Thank you very much. So I don't have aphasia. Excellent. Okay. So I'm going to share with you briefly some thoughts on acute stroke and sickle cell disease. And this is going to be the outline of the presentation. Although the focus on acute stroke, I'll just touch briefly on the epidemiology of stroke, especially in the sub-Saharan African setting, touch briefly on the pathophysiology of stroke in SCD, the clinical manifestation that will help you to be able to pick it up, and then spend a bit of time concluding with some thoughts on the management of stroke, the acute management, primary prevention, and secondary prevention of stroke. Now, when we say stroke, what do we mean? Essentially, a stroke occurs when the brain, the needs of the oxygen and energy demands of the brain are not met by the body. And so this may occur because there is a clot that blocks a blood vessel that is perfusing the brain. And when that happens, enough blood is not able to get to the site, and then the tissue over there undergoes necrosis, and then infarction, and then it dies off, and the function of that part of the brain is lost. And so they will present acutely, suddenly, because the brain needs oxygen around the clock. So that's one main mechanism for stroke occurrence in sickle cell patients. And then the other common type of stroke that we tend to see is the hemorrhagic stroke, where the blood vessels are fragile and they break, and then the person bleeds into the brain for a hemorrhage to occur. So what is the epidemiology of stroke in sickle cell? Well, if you look at most of the complications in sickle cell, one of the most devastating of them is actually a stroke. And I'm, by disclaimer, an adult physician, a neurologist who sees a lot of strokes. And occasionally I do come across strokes in the context of sickle cell. So for me, it's a learning opportunity because I envisage that a lot of the people on this session are pediatricians and clinicians who have probably seen more strokes in their lifetime than I do. However, I just want to share with you that we all agree that there is a high burden of stroke in sickle cell patients, and it's an important complication to be aware of. Now, when you compare with their peers, children with sickle cell have a staggering 221-fold increase in stroke risk and a 410-fold increase in cerebral infarction risk specifically. So for children with sickle cell, prior to the onset of use of interventions like hydroxyurea and the rest, there is and still continues to be a very high risk of developing a stroke or suffering a cerebral infarction compared with their peers. Indeed, evidence from most of the studies, the corporate study, has shown that 11% of patients with sickle cell anemia will have a clinically apparent stroke by age 20 and a 24% risk by age 45. What is the burden of stroke in the sickle cell population in Africa? literature, systematic review of about 30 studies from Africa has pegged the prevalence of stroke to be about 4.2% in individuals living with sickle cell disease. And if we were to take it country by country, and admittedly, most of the studies that have looked at stroke in Africa have emanated from Nigeria, the rates of stroke appear to vary between a prevalence rate of 1% to about 12% in Nigeria. And it is believed that this prevalence varies depending on the sample size assessed and the types of methodology that was used to establish the diagnosis of stroke. So sample sizes that are small tend to pick a higher prevalence of stroke, and sample sizes that are very big. So sometimes, I think one of the studies in Maiduguri assessed over 5,000 patients, and they found a prevalence of around 1.2%. If you go to Cameroon, the prevalence is about 7%, DRC about 1%, Uganda 6%, Kenya 7%, and Tanzania, you have about 8% of individuals with sickle cell having a stroke. Recently, we published a study from Ghana where we looked at over 4,000 individuals across the lifespan, and we assessed the prevalence of stroke. And then we found that about 0.9% of our population had stroke. We think the lower rate of stroke in this population could be due to the high usage rates of hydroxyurea in our clinics, and the use of newborn screening to identify individuals that are enrolled in our clinic. So a follow-up study might be needed to understand why the value was so low in our setting. So let's look at pathophysiological consideration of stroke and in sickle cell. So we know that the sickle cell is a very sticky cell, and that it has abnormal adherence to the vascular endothelium. And this involves the elaboration of the P-selectin, which makes the sickle cell stick to the endothelium. And also via a process of hemolysis, the hemolysis tends to lead to activation of the endothelial cell and create a hypercoagulable state, which together with alteration in the vasomotor tone, whereby we have endothelial thickening and then smooth muscle proliferation, it creates occlusions or stenosis, and that increases the risk of developing a stroke in a sickle cell context. Now, when it comes to manifestations of stroke, it's important to understand that we have overt strokes, which you can see clearly, and then we have silent or covert strokes. In fact, it is believed that silent strokes or covert strokes are about 10 times as common than overt strokes. So an overt stroke typically is due to a large artery vasculopathy that affects the intracranial internal carotid arteries and the proximal middle cerebral arteries. And those are the areas where you tend to see a lot of occlusive changes, and that is where stroke occurs. And unfortunately, the internal carotid artery and the proximal middle cerebral arteries perfuses very, very important or sensitive areas in the brain. And therefore, if you have occlusion in those areas, it tends to be symptomatic. And the silent strokes, on the other hand, sometimes it's tricky to even use the word a stroke because you can't have a stroke that is silent. What we mean to say is that if you have, let's say, an infarct that sits in an area that is not eloquent, it's not eloquent because although you have evidence of tissue injury, you are not having clinical symptoms to go with it. However, if you do very dedicated testing for cognitive function, sometimes they are not as silent as we think it is because it has impact on the cognitive performance, has impact on predisposition to seizures, it has impact also on the emotional state of individuals who have these infarcts. So continue with the pathophysiology. So the cause of a stroke in a single individual can be heterogeneous. And so it's important to understand this as well. And in children, we know that cerebral infarction predominates, whereas intracranial hemorrhages also tend to occur more commonly in adulthood. But that is also not to say that, let me put it this way, in adults, infarcts are commoner than hemorrhages. But if you look at the proportion of individuals who have, let's say if you take a lot of adults who have had a stroke and they are adults, they are likely to have more intracerebral hemorrhages in adults than if you were to compare the proportion in children. So the most common subtype of overt cerebral infarction is really what we call the border zone stroke. Now, when we say border zone stroke, it means that you have an anterior cerebral artery and you also have the middle cerebral artery. And the zone between the territory where the anterior cerebral artery and then the middle cerebral artery works is what we call the border zone. That border zone is quite prone to infarcts. And so when you have this progressive luminal narrowing in sickle cell patients over time, then they tend to compromise those border zone areas. And those border zone areas are the ones that tend to get infected a lot. And those are quite difficult to manage because the outcomes are usually not very good. So how do I identify a stroke in a sickle cell patient? Well, it is important to understand, first of all, that there are types of strokes, and these different types of stroke tend to present sometimes differently. So the commonest by far is what we call the acute ischemic stroke, and they tend to present with sudden onset of painless hemiparesis. Painless hemiparesis, and the emphasis is on painless because when those strokes are occurring, they don't present with pain. So if a patient presents with weakness and there's pain, you may have to think carefully whether it's a stroke or not. And they may also have what we call hemisensory loss, where they lose sensation one half of the body, depending on which part of the brain is affected. Then you may also have what we call visual field cuts or hemianopsias. So sometimes they may present because they bang into doors, they walk and they don't see, and they hit their head and stuff like that. So visual field cuts may also be a presentation. And also you may have ataxia. Ataxia is lack of coordinated gait. And so they may present with an unsteady gait, loss of balance, and this could be a manifestation. Dysphasia or aphasia is loss of speech. And occasionally, if the stroke is big enough, you may have loss of consciousness. So acute ischemic strokes rarely may present with loss of consciousness. However, if the infarct is massive or big, then the raised intracranial pressure could lead to presentation with loss of consciousness in an acute ischemic stroke. Then we have what we call the acute intracerebral hemorrhage, where the person presents because the person has bled suddenly into the brain parenchyma. And usually when that occurs, it will present with severe headache at the outset, or they may present with new onset seizures. So when a sickle cell patient is presenting with seizures, it's important to consider an intracerebral hemorrhage as the reason for the manifestation. And sometimes they may present with loss of consciousness with or without hemiparesis. So a person presents with loss of consciousness. Okay, they tell you he was in the house, he was playing, everything was fine. And all of a sudden, we found that the person was unconscious. And when it comes to the hospital and you're assessing, loss of consciousness is something that's very difficult to assess in a context when you don't have access to CT scans, because loss of consciousness can be due to so many things. But if the person presents with loss of consciousness, then an acute intracerebral hemorrhage is one of the differentials that you must consider. Now, stroke can also present acutely in the context of a subarachnoid hemorrhage, where the person bleeds into the subarachnoid space. And the clue is that they may present with headaches with neck stiffness, headaches with neck stiffness, and often it's without a fever. And so, and then rarely, I've seen a few cases with central venous sinus thrombosis, where you have an occlusion of the dural sinuses. And those ones, when they occur, they may present with headaches and seizures, which may not be different from an intracerebral hemorrhage. And sometimes if you don't have an imaging to be able to differentiate between the two, sometimes it's very difficult. But one of the keys is that they may have focal neurosymptoms. And in venous dural thrombosis, interestingly, they can also have bleed when you take the CT scan. The difference between the two, I would say, is that with the central venous thrombosis, the bleed tends not to be very territorial. So you may have a bleed that is on both sides or both hemispheres. And that's one clue to picking up central venous thrombosis. Rarely, you may find what we call the posterior reversible encephalopathy syndrome in the context of sickle cell patients, where perfusion to the posterior circulation is impaired, and they may present with altered mental states, headaches, and because it's in the posterior circulation, they may present with blurred vision and visual changes. Often they tend to go with very high BPs, and so it's important to look out for that as well. Now, one of the manifestations of stroke is what we call the silent infarct, which I've alluded to earlier. It is important not to reassure your patients that silent infarcts are benign. They are not. Silent infarcts can be associated with an epileptogenic focus, and that can be the source of seizures in sickle cell patients. Also, silent infarcts can serve to cause cognitive decline. So the academic performance may be poor in school because of these silent infarcts. So they are not benign. And I think that that's one important thing to take away from this particular presentation. So when a patient presents with acute stroke, how do I approach the management of such a patient? Well, you need that clinical acumen, first of all, to be able to pick up that the symptoms of neurologic deficit started suddenly. And the emphasis is on how sudden the neurologic deficit evolved. Because if it is not sudden in onset, it may be due to so many different things, like an abscess. An abscess can occur in a sickle cell patient. Meningitis can occur in a sickle cell patient, and they may also present with some of these deficits. But if a person tells you the symptoms started suddenly, the neurological symptoms started suddenly, it's important to think and consider that it could be a stroke. And of course, in the developed country setting or in certain tertiary centers, we have CT scans, we have MRIs, and if the patient can afford, then a prompt neuroimaging is needed and required for us to be able to confirm the stroke type, because the stroke type tends to influence what you do for the patient, especially when the person has an ischemic stroke. Then for ischemic strokes, in developed settings, you want to quickly approach it with rapid SCD transfusion, which is the standard of care. And the main goal is that you want to reduce the fraction of hemoglobin S to less than 30% using the emergent RBC transfusion. Now, we know that in our setting, we don't have this mode of treatment available to us. So if the HB, you can have access to AA blood, then we have to transfuse to bring the hemoglobin concentration to about 10 to 11 grams per deciliter. And that's because somebody's writing on my slides. Anyway, always. And that's because if you're able to bring the hemoglobin concentration up, you're able to improve oxygenation to the tissue and able to then limit the level of infarction. Because once the brain tissue undergoes infarction, there's no turning back. You can't bring it back. But if you transfer the patient early, you're able to improve oxygenation and limit the level of tissue injury to the brain. Now, unlike other populations where thrombolysis is what is used acutely for the management of an ischemic stroke, unfortunately, we don't have enough evidence to suggest that thrombolysis could be used in the context of sickle cell individuals. And the evidence seems to suggest that there's a higher risk of bleeding in that population. Plus, thrombolysis has also not been tested largely in children. And in sickle cell patients, most of the strokes occur in the young. So this is another area of research that has to be looked at, because there are a lot of programs that are helping to reduce stroke occurrence in the developed countries, but we still tend to see a lot of strokes in the young. And if there is a place in the world to consider thrombolysis studies for acute stroke, maybe this is a part of the world to look at it. Now, also in adults, anytime I see a stroke patient, it's an ischemic stroke, quickly I start my aspirin, quickly I start statin use. But however, in sickle cell individuals with ischemic stroke, the role of aspirin, the role of statins is so controversial, because I think that we haven't done enough studies to assess their effects in our context. So you will agree with me that the acute management of stroke, we are quite limited in what we can do. So of course, when the patient comes, you sort of want to transfuse if you can. You sort of want to identify risk factors that are present. You want to manage the complications that are present with a stroke. So for instance, if there's seizures with a stroke, you have to stop the seizures with phenytoin. If there's aspiration pneumonia, you have to treat aspiration pneumonia that is associated with a stroke. And all those management principles have to be followed. But you will agree with me that for most of us who are seeing patients in clinic, who have large patient caseload, the focus really should be on primary prevention, which is that you identify patients without a prior stroke who have high risk of stroke, and you want to be able to use transcranial Doppler ultrasound to screen for those who have high risk and therefore put them on prophylaxis so that you can reduce the risk of developing a stroke. So the transcranial Doppler measures the velocity of blood that is running through the bilateral median cerebral arteries, and it relies on the Bernoulli effect, in that in sickle cell, the progressive narrowing of the intima causes a narrowing of the lumen, and therefore when you narrow the lumen, flow velocity increases. And so if you pick up a high flow velocity, it suggests that the person is at high risk of developing a stroke, and therefore that can guide how you manage such a patient. So in fact, if you have a timed average mean maximum velocity of more than 200 centimeters per second, is associated with a 40% increased risk of stroke within 3 years. And so that cutoff value is important. And the gentleman who did this, Adams, is a gentleman, I think he's in a Medical University of South Carolina. I had opportunity to meet him when I went there. He's a very nice fellow, but he did a lot of work on using the TCD to guide transfusions for sickle cell patients to minimize the risk of stroke. Having said that, the established standard of care for preventing strokes is transfusion, which, look, won't work here. We don't have the capacity to do it, full stop. So we'll move on. We've now moved on. We are looking at hydroxyurea for primary prevention of stroke. And it seems that evidence from the study that was done in Nigeria, the SPRING trial, showed that low-dose hydroxyurea versus moderate-dose hydroxyurea had comparable effects on the stroke incidence rate. So due to that landmark study, I think that we are all confident in using hydroxyurea in our context. This is research that is tailor-made for Africa, because hydroxyurea, for me, is a savior when it comes to preventing most of the complications of stroke. However, what do we do once the person has already developed a stroke, which is secondary prevention? Well, unfortunately, the data seem to suggest that hydroxyurea alone may not be as effective as chronic transfusions for secondary prevention of stroke in terms of stroke risk and iron overload. But I think that what we have to bear in mind is that most of these studies comparing hydroxyurea and then transfusions need to be done in Africa to see if we get a benefit. Because for me, if you don't have the means to be able to do this chronic transfusion, then it's not an option to start with. So maybe for us, we'll still have to use the hydroxyurea for secondary prevention because there is some benefit, but it's not as effective as chronic transfusion. So there are new drugs on the horizon, but in the interest of time, I'll just touch on them. Hematopoietic stem cell transplantation is not something that we can do in Africa for now, but in the future. And then volixitor can also be used, but that one, when they did a trial, we found out that it stabilizes the hemoglobin S in the oxygenated states. It prevents polymerization. It prevents erythrocyte sickling. But unfortunately, the HOPE trial that they did not measure stroke incidence as an outcome. And there are also monoclonal antibodies that can also prevent vaso-occlusive crisis and has been found to be helpful in acute chest syndrome. But we don't know whether it's also helpful in stroke. So those are things to look out for. So on the ground, what can we do in Africa to be able to minimize the incidence of stroke? One, we have to be able to establish the incidence of stroke, especially with the advent of hydroxyurea. A lot of our clinics are using hydroxyurea. So we have historical data on how common stroke was. And we need to know, now that we are using a lot of hydroxyurea, how common is stroke. So some of the studies that we are doing in Kumasi is looking at that. But it would be great to look at other centers across Africa and see, is there any temporal change in the incidence of stroke? And then we also have to look at questionnaire-based screening for stroke symptoms, because we see a lot of patients in clinic, and sometimes strokes can be very subtle. And so we need to sort of go out of our way to assess it in a very methodological fashion to be able to, and there are tools for that that we use in our clinic in Kumasi to assess that. But it's still undergoing pilot testing, and it'd be great. I've spoken with Obi, and a study in Nigeria, between Ghana and Nigeria, is about to start soon. We also need to evaluate the impact of stroke on neurocognitive performance, and then build our national capacities to conduct clinical trials on both primary and secondary prevention, as well as acute management of stroke. So I'll end here in the interest of time. Thank you very much for your attention.
Thank you very much, Professor Safo. Thank you for your very beautiful and practical presentation. Thank you. Just to remind us that Professor Safo is one of the MPIs on the SPAT train. So the floor is open for questions. I don't seem to see any questions in the chat box. Please, if you have any questions, just raise your hand and you unmute yourself and ask your questions. Any questions, comments, clarifications? Hello? I hope we are still audible to participants. Hello?
Yes, you are. Very audible, sir.
Okay. Any questions?
Hello.
Okay, we're seeing comments. Excellent presentation. Okay, so there's a question, Prof Safo, there's a question on the chat which says, please, which among the types of stroke is more common?
Yes, so thank you. So in terms of ischemic versus hemorrhagic strokes, ischemic strokes are way commoner than hemorrhagic strokes. So in the African context, ischemic strokes may constitute about 70%, whilst hemorrhagic stroke may constitute about 30% of all our strokes. Now, if you bring it in the context, if you compare that with, let's say, the developed world, ischemic stroke will constitute about 90%, hemorrhagic stroke will constitute about 10%. So it will suggest that hemorrhagic stroke proportionally is still commoner among Africans than in the West. And there are several reasons for that. The African is believed to be prone to a hypertensive phenotype that puts our small vessels, the penetrating small vessels in our brain, at risk of forming these small aneurysms. And this small aneurysm can rupture and bleed and cause an intracerebral hemorrhage. So a very short answer to your question is that ischemic stroke is still commoner than hemorrhagic stroke in Africans, except that the proportions differ when you compare it with the developed world. Over.
Thank you very much. There's a comment from Professor Madu that says that the prognosis of stroke outcome is dependent on how soon after an exchange transfusion can be done. And there are quite a number of commendations for you, Professor Safo, on the platform for a well-detailed lecture. We thank you, and as well thank every other person who's presented today, Professor Alex Ufeyakutu and Dr. Teka Atim. I would like to, at this point, call up Professor Nodu to close the session for us. Prof Nodu.
Yes, good afternoon, everyone. I must say that I'm extremely delighted to have this session, this presentation by a team of highly cerebral scholars present, management of acute chest syndrome, priapism, and stroke. To us, I have learned a lot, and then also learning from the people who have made some comments. I'm really glad that this multidisciplinary training in sickle cell disease, has taken off, and we are delighted to present it, to all. So just by way of a short story, when we did the Sickle Pan-African Research Consortium, the first iteration of it, which was 4 years, my body, Professor Alex, and I co-led the skills development working group. We led that, training, across the 3 countries for 4 years. But we felt that it wasn't sufficiently, in depth. We didn't have the depth. The research focus was not quite there, and we felt we needed to go deeper. So so we now applied for this Fogarty International Center D43, in order to, have in-depth training in clinical research for the people across the 2 countries. So the grant is building on what we did in Sparkle 1, and we also noticed some gaps in implementation science. So 4 of us came together. Professor Fred, who is the PI for Sparkle Ghana, Professor Alex, who is the PI, the first PI for Sparkle Ghana, and then Emmanuel Pepra, who is an implementation science expert from NYU, and Priska Olabisi Adejumo, who is a research professor of nursing from the University of Ibadan, along with co-investigators like Professor Maxwell, Professor Jengbede, and all. So we over the next 5 years, we will run a highly innovative, interdisciplinary, and interprofessional training program that builds on what we have done. Stroke is a world, Professor Fred is a world-renowned stroke expert, and he participated, in the H3 Africa Stroke Consortium. So we are going to build on that, and our focus is to address the translational research gaps and bring evidence-based. evidence-based interventions, to our people. You will notice that already we're having a training in bioinformatics by Professor Nash. We are already having some training in implementation science by Dr. Pepra. And then we're having this multidisciplinary training. We have already concluded some training in genetic counseling, which Professor Akiola is hosting with some people from the US. So we're going to actually expose physicians, and biomedical scientists, nurses, and medical labs scientists across the 4 institutions, to this research training. Is really focusing on research training to enable us to do some work, neurological, renal, cardiovascular morbidities, and other hemoglobinopathies. So we aim to recruit some talented scholars and give them in-depth research training, mentoring. Professor Fakori is there. He's leading an aspect of this training, and we want to be able to really focus, on research, in these areas. So I'm really delighted. I've been wanting to hear Fred speak for a long time, and I'm really delighted, that he's been able to give us this presentation. And not only Fred, but Alex, and I'm getting to meet Dr. Intem now. So we had a wonderful time yesterday, and I want to thank everyone, for attending, and staying to the end. So we'll be sending out the adverts for each of the programs, and I would suggest, that you apply for them. We are going to have boot camps on genomics boot camp. We are going to have different iterations of the genetic counseling training, different iterations of the implementation science training. So please try and apply and participate. I know that a number of young people are fleeing the continent, but even if you want to leave, it's still good to have the opportunity to get some training under your belt, as you go. So I want to thank Professor Maxwell for leading this first iteration of the multidisciplinary workshop. The next one, we are going to be emphasizing on pregnancy, related complications in sickle cell disease. And then it will be led by Professor Jengbede. So there will be many of these. We are going to take it at a high level. And we really would want to appreciate if people invite the teams that they are working with in their hospitals. I want to thank every member, every SPARCO PI who is here, and then all the members of the team that we are working with in the different hospitals. SPARCO in Nigeria is, we are working out of 25 clinical centers. And so in Ghana is a university, Kwame Nkrumah University of Science and Technology in Ghana, where my buddy Alex and Professor Safo are working out of. And I noticed that there are also people from across the Sickle Pan-African Research Consortium from different countries. So we've had a good time. I want to appreciate everyone, and I particularly want to appreciate our leaders, in the field, Professor Esau, Professor Akiola, Professor Asala, and all the other people. I want to appreciate you, and I thank everyone for attending. Thank you very much.
Thank you very much, Professor Nodu. Please, may I humbly request that we very briefly just put on our video so that we could take some screenshots of participants, please?
Pretty please. It depends on where we are.
Yeah,
okay.
those who can, please. Ruben, please try to do it as quickly as possible.
Yes, more cameras coming on. We're waiting.
John?
Good afternoon.
Hello.
Yeah, I would like to send my warm regard to Mr. Ruben. I'm research assistant from FMC Brenning KV. Anytime I call
Oh,
on him
okay.
for more clarification, always answer to my call.
Yes.
So please, my
Thank you.
warm regard to Mr. Ruben
Okay.
and Albarka
Okay.
Isa too.
Okay. Thank you very much for that. Yeah. Okay.
Yes.
Shall we take the
Yes, ma'am.
screenshot? Ruben, have you taken the screenshot?
I'll take it now.
Okay. All right. Ah, Professor
Yes,
Madu.
one more. One more.
You've been okay.
Hi, Eunice.
Who is doing Eunice here? Who is Eunice? I'm not Eunice, so I'm Obi Nodu. Alex, you're calling me Eunice.
No,
Yes.
Obi, he was calling Eunice from Kumasi.
Okay. All right. Okay.
How are you? Good.
I'm
Thank
fine.
you,
I'm glad to
everyone.
see
Thank
you.
you.
Okay. Bye-bye.
Bye.
Bye.
Bye, everyone.
Bye. Bye.
Bye.
Bye.
Okay.
Bye-bye.
Bye.
Bye.
Bye. Thank you so much.
Bye.
This was
IJ.
great, ma. Really
Fantastic,
great.
right?
Bye.
Honestly.
So detailed. So detailed.
Honestly, we're having a good time of learning, Yeah. So we're just going to
Yesterday
put
was
them on. Yeah, yesterday was great, but I've been waiting to hear Professor Sacco speak, and I'm glad. I'm really glad. Yeah. Okay, dear. Okay. So see you people, as if we should stay here. Well done.
I know.
Yeah.
All right then. Bye-bye.
Yeah. Okay, bye-bye.
All right, bye.
Bye.
Bye.